Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghvamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the tetanus. Tetanus is a contagious disease caused by the organism Clostridium tetani, a gram-positive organism and is an obligatory in a row. The organism produces a toxin. The organism is common in manure and soil. The complex conditions for growth and toxigenesis rarely coexist and cause disease. Tetanus is a wound infection, deep contused soil contaminated injuries infected with a pyogenic organism and containing foreign bodies are likely source of tetanus toxemia. The disease is wholly produced by exotoxin, which damage the central nervous system, causing dual action as interferes with acetylcholine esterase balance at peripheral motor end plates. So, excess of acetylcholine clinically producing a sustained state of tonic muscular spasm. In another action, it causes extreme hyperexcitability of motor neurons in the anterior horn cells, resulting in explosive and widespread reflex spasm of muscles in response to even minor sensory stimuli. The toxin producing such effects is fixed in the tissues and can't be neutralized by antitoxin. Only free toxin can be neutralized. Clinical features. The incubation period is fallacious as it is very long. The prognostic index is the period of onset. It is the time between the first symptom and the first reflex spasm. If this period is less than 48 hours, death is likely. As the period of onset lengthens, the prognosis improves. First symptoms. The first symptoms are the difficulty in swallowing and stiffness of the jaw, pain in the neck, back and abdomen. Then tonic muscle spasm develops, sparing the limbs relatively. The sardonic smile of tetanus is evidence of this stage of the disease. There is a considerable difficulty in swallowing and reduction in breathing capacity. Thereafter, reflex convulsions can occur affecting all the muscles, causing great pain, opisthotonus, and sometimes muscle rupture of psoas, rectus abdominis, and pectoral muscles. These spasms are spontaneous or may be induced by even trivial stimuli of notice, injury, or movement. If spasm is severe, they stop respiration and the patient becomes cyanosed, which threatens life. Tonic muscular spasm remains between reflex attacks, which differentiates from the strychnine poisoning. Temperature. Temperature is usually little elevated and the pulse is rapid. In the early stages, it may be mistaken to the tonsillitis, back strain, acute abdomen, and hysteria. Treatment. The patient is isolated in quietness and comfort. It is not necessary to excise the wound. If pus is present, may be drained, but ordinary wound toilet is sufficient. Anti-tetanus serum, ATS. 1 lakh international units of anti-tetanic serum is given at once, half intravenously and half intramuscularly, to limit the further fixation of toxin. Unless the patient has previous horse serum, the ATS need not be repeated. If available, human anti-tetanus globulin ATG is preferable to ATS. Only one dose is needed. In treatment, as in prophylaxis, tetanus antibody material, whether heterologous or homologous, is the only substance capable of neutralizing the toxin which caused the disease. Further treatment resolves itself into three stages dependent upon the development of the disease. Stage 1, a mild case. In this case, there is a tonic rigidity without swallowing difficulty or effect on respiration. Here, the initial sedation is by intramuscular promazine sparing 100 to 150 milligrams and amylobarbital 200 milligrams, or to be continued 6 hourly. Stage 2. It is a seriously ill case with swallowing difficulty. There may be reflux spasm with no cyanotic episode. A nasogastric tube is passed and sedation continued. A liquid balanced diet containing 2000 calories and 50 grams of protein is given by the tube unless blood urea rises when the protein is temporarily discontinued. If the patient has difficulty in breathing, he will require tracheostomy to maintain clear airway. The operation is done under local anesthesia and a cuffed tracheal tube must be inserted. Nursing includes meticulous care of tracheostomy, tube, posture, suction and humidification. Sedation is to be continued. Stage 3. It is a dangerously ill stage if the patient has cyanotic convulsions, needs third stage of treatment. Curare in a dose of 25 to 40 milligrams is given intravenously initially and then intramuscularly to maintain complete relaxation. Simultaneously, intermittent positive pressure respiration must be provided till the muscle spasm occurs, usually 12 to 30 days. Sedation is stopped. This last stage treatment makes such demands on medical and nursing services that it can only be used safely in a special respiratory unit. Such a case requires over 350 individual acts of nursing services each day. A special nurse continuously, while the monitoring requirements of artificial respiration needs special equipment and skill. The care of the dangerously ill case is worsened by the development of complications made possible by the unilateral preservation of life brought by artificial respiration. Such patients may develop severe negative nitrogen balance, myocarditis, vascular failure associated with extremes of blood pressure and pulse rates, and severe damage to the motor neurons in the cord and brain, leading to a major paralysis due to toxins. Thus, though the life is saved, patient may die of lethal dose of toxin of the disease. Thus, though the major therapeutic effort is exerted to control the spasm and respiration, the general care of the patient is not forgotten. Penicillin and streptomycin are needed to prevent infection. The eyes must be protected while curare is used to prevent a rapid development of conjunctivitis. Curarized patient is unresponsive but is conscious and sensitive. Prevention. Active immunity. Active immunity is conferred by injection of adsorbed toxide. 1 ml is injected and repeated at intervals of 6 weeks and 6 months and followed by a booster dose every 5 years. If such an active immunity is present, an extra dose should be given at the time of injury. Passive immunity. Every patient with an infected wound who has no active immunity must have an intramuscular injection of 1500 units of anti-tetanic serum ATS given with the due precautions. Then he must have active immunization with toxoid. Many people develop immunity to horse serum. So if the patient already have a dose of horse serum for one accident, he is likely to destroy the serum given at the time of next injury. In such a case, large doses like 50,000 units should be given and repeated every other day in the hope of staying the disease and allowing time for toxoid to produce a permanent immunity. It is to be remembered that a prophylactic dose of equine antitetanic serum is probably only useful once in the life of a patient. The inherent disadvantages of the equine antiserum ATS can be avoided if human anti-tetanus globulin ATG is available. This is an homologous antitoxin and its protective value is 100 times that of the heterologous equine type. A dose of 250 units of ATG will give adequate cover during the period needed to establish active immunity. Much has been written about the penicillin and other antibiotics in preventing the onset of tetanus. Though the organism is sensitive to penicillin, it must be remembered that the condition of growth in the infected wound make access to the antibiotic difficult. The spores are unaffected and is capable of surviving till the antibiotic disappears. It is essential that every patient who had anti-tetanic serum should be immunized at once with toxoid. That's all about the tetanus, and in the next video I will discuss about some other disease. Thank you.